Welcome, everybody. I welcome you all to this session at the conference Future of Dentistry Virtual Dental Conference 2020. In today's session, we're going to be talking about innovations in endodontics amid the COVID-19 pandemic. I am Dr. Bakhtawa Razar, and I am an infection control instructor at the Dental Department of IPAC Foundation. With us, we have Dr. Professor Khalid M. Ahmed, who is a practicing endodontist in the US, as well as a professor in operative dentistry at the College of Dentistry, University of Lahore. Welcome, sir.
Thank you very much. I welcome everybody in this international virtual dental conference, which is being held. Uh, Not only I welcome all the participants who are joining us, I also thank all the people who have worked very hard to put this thing together and connecting people from all over the world so we can all share our ideas, innovations, and tips to deal with this latest problem we have with this novel coronavirus. My name is Dr. Khalid Ahmed, and I am an endodontist in United States. I'm also a visiting professor at University of Lahore in restorative dentistry. I have been practicing for almost 35 years, teaching endodontics for many years. And we really, those of us who have been practicing for a long time, we haven't seen circumstances like that over a long period of time. So we have to learn to cope with this. I have been given the topic to deal with innovation in endodontics amid COVID-19 pandemic. So I think uh, there are few things that we can do to make our job easy to practice. One of the innovations I'm going to mention currently, really, there are no innovations that have come into play within the last 6 months since the pandemic had started. The only innovations have been in infection control, which we were following it before. Anyway, I think just the environment we work in, there are a lot of infection control lectures and experts talking about that. But as far as the innovations are concerned in technology and treatment, there is nothing. All we have to do is revisit what we have and reapply what is already available. I think we have the best of the technique and the technology already available, and we just have to revisit and reapply the application of that. And what you see on first thing I like to mention is the time wise. I think we have to better allocate our time, how much time we spend in the clinic. We have to focus on treatment planning so we can reduce the amount of time we spend in the clinic, have the minimal exposure, and get the maximum output as far as the treatment is concerned. We should look in the technology, what technology we have available to do our procedures, and then what are the different treatment techniques available to us, how to use them, and the last thing is how we can learn while we cannot even travel. We have banned on a lot of things. We cannot hold meeting, we cannot hold lecture. So how we can best use the information and apply the information. Okay? In my opinion, with the current condition, a prudent clinician performing endodontic procedure in current conditions should take minimum procedure time. We have to reduce our our exposure time uh, to these microbes, to these contagions. We must learn and use the best technology available to us, and we must practice the modern techniques so we have a predictable outcome. Let's talk about what are those innovations that we have. There are different topics that I will be discussing. And on the top, what you see is diagnosis. And I think we should focus on treatment planning. We should focus in radiology, visualization, working leg determination, how we can do the instrumentation, what is the best technique for irrigation, obturation, what are the root canal sealer available to us that we can use in this difficult time and reduce the treatment time and get the best result. We should look into regenerative endodontics, and then what is the best way to handle emergency patient in this situation. The picture you see on the right is an example. You see two birds. These are called hummingbirds. Hummingbirds are native birds of America, both North America and South America. There is an amazing thing about these birds. These birds went under a transformation over 40 million years ago. When they were having shortage of food, they were insect eating, but bug eating birds. But in the age of dinosaur, these birds are only 2 to 3 millimeter uh, long, and they have to modify. The scientists are looking at how these birds survive for over 40 million years. What did they do? And they found out that it was the transformation. They transformed themselves physically and habit wise. They were bug eating, they turned themselves into sucking nectar. These are the birds who can suspend themselves in the atmosphere. They can splatter their wings almost 80 times per second. They are very high. Their metabolic rate is very high, so they need a lot of energy. And I think we have a lot to learn from that as a dentist. Now, what these birds do is instead of wandering around all day looking for bugs, 20 million years ago, they learned if they suck on nectar, get high energy, they only go to a couple of flowers and they're done for the day. And this is, I think, what we have to do. We have to make the planning. We have to evolve ourselves. The topic I had shown you before, the diagnosis was on the top, and then the treatment planning. But I'm going to reverse the order. I think the main thing we have that we should focus on in this pandemic is treatment plan. We should have a strategy for success in this environment. How can we have a single visit and we can have a profound anesthesia? We can have multiple procedures done in one visit. We can comprehend that visit, not only do root canal, but also treatment plan, root canal to the restoration. Patient walk out with a lot of things done uh, that we were accomplishing it in 3, 4, sometimes 9 visits. We should spend the minimal time with the maximum output. We must plan our practice so we can deal with the situation we are in right now. So the first innovation in endodontics right now, I think we should focus on the treatment planning, okay, before the patient comes in. We must know what we will be doing. We cannot spend 3 to 5 visits just to finish a single rooted tooth root canal procedure. Okay? In one visit, we should be able to do the root canal. We should be able to provide the restoration. We should be able to do the crown prep. Okay, and maybe patient leaves with a temporary. Now we were not doing that, but with the current condition we have right now, with the PPE, with the mask, with the face shield, with covering our head, with the staff, with leaving the rooms for a half hour or 15 minutes. Once we clean the room, we must strategize and come up with their treatment planning. Even the practice management. I know some people here in the United States, they're thinking about getting out of solo practice, getting in the group practice. They can all practice together. They can share the technology. They can share the resources. They can share the staff. Some are even thinking to have evening hours in the same office. Group practice is going to be the way of practicing in the future. So we can uh, basically plan, not only treatment plan, but even the practice plan. So that is first innovation. Second thing is diagnosis. I think we should re-innovate. We must relearn how we pick up the signs, the symptoms, how do we perform the test, what tests are needed to perform on these patients. So we can reduce the time. We don't have to do all the tests all the time, but we have to do enough tests to reach to a diagnosis. Okay? The X-ray you see on the screen, there are three teeth. First bicuspid, something is wrong with that. You can see deep restoration with a periapical lesion. You see the first molar with the root canal, probably silver cones. Decay under the crown. The third tooth you see is a large crown with recurrent caries underneath, plus periodontal problem. So this patient, when this patient come to us in emergency with a pain or endodontic problem, everything is something is going on in there. So we must diagnose: is it the bicuspid giving the problem? Is it the tooth with the root canal giving the problem? Is it the tooth in the back giving the problem? Is it a endodontic problem? Is it a periodontic problem? We must be able to diagnose, come up with a treatment plan, and then proceed with the plan. Okay. The next thing with this COVID-19 pandemic, to deal with the novel coronavirus, we must be using the best of the technology available. In radiography, digital radiology has come long ways. Due to this current clinical condition, digital radiology is a necessity to perform root canal treatment efficiently and effectively. I cannot even imagine doing root canal without digital radiograph. Those of us who are using it, we know how valuable tool it is. You can use this on your laptop, you can use it on your desktop, you can connect to different rooms, you can take the image in almost 10 seconds, you have the image again. You can see all the images together, you can see the images in color, you can go back and see images. You cannot wait for 5 minutes, take an X-ray, go back, develop it. I think that is thing of the past. So the next innovation in endodontics after treatment planning is digital radiography, and I think dentists must look into that to reduce the exposure time and get the maximum output from the clinic when the patient is there. The next factor is visualization. Now, these gadgets have been around with us for quite some time, but we are not using them. My concept of innovation is let's go back, visit, reuse it. Visualization, which is magnification and illumination. We must be using the loops, which is magnifying glasses. We must be using headlights. And those of us who can afford microscope, who can use microscope, almost 90% of the endodontists are using microscope. But those countries, those areas where you don't have access to this technology, and I understand these are expensive, at least use the basic thing. The basic headlights, LED lights are tremendous help to visualize things. The loops are, to me, is a necessity. If you take my loops from me, if you take my digital radiology away from me, I won't be able to practice. Okay, and I went to dental school in the 70s. I started from the scratch when this technology was not there. But even myself today, I cannot go back. I think this is a innovation to us, and we must be using it. Okay, so this innovation of magnification and illumination is very vital to us. Okay? Next thing, which is a very novel thing, is not new, rubber dam isolation. It has tremendous benefits, protection from the virus. This is, in my opinion, the best tool a dentist has to deal with coronavirus. It protects you from the virus. It protects the patient infection transmission. It makes your job very efficient. It makes your job very effective because you have less contamination and you have a better outcome. I still don't understand why dentists are not using rubber dam, because a rubber dam is one tool you have. You can really isolate the area and perform the procedure very effectively. Is a simple procedure to learn. Rubber dam isolation, all I can say is damn it, because it is in your benefit. It is in the benefit of the clinician, benefit of the patient, and benefit for everybody. We keep talking about corona control. Now, I'm not infection control specialist, and we have many people who will come on the panel and give lectures on that. I am a clinician. From clinical standpoint, to deal with this contagion, the best thing is before you start the procedure, give a rinse. What you see on the left hand is hydrogen peroxide, 3%. We give hydrogen peroxide over rinse to the patient. You can use straight out of the bottle. I personally don't like the taste. Patients don't like the taste. You can dilute it 50%, half water, half hydrogen peroxide, give that to the patient and let them rinse, and you have a control on that virus already before you even start. Once you start, the contagion is everywhere. The next thing is application of rubber dam, the use of saliva ejector, use of high-speed evacuation. The third picture you see is, I think if you can learn anything in the practice in this environment is learn the use of rubber dam isolation, use of saliva ejector, and high-speed evacuation all at one time. When I do root canal, I put the rubber dam on. Rubber dam is there all the time. That's why I use plastic frame. I don't even have to take the frame off to take radiograph. I put the saliva ejector right away. As soon as the rubber dam go in, my high-speed suction goes up right away. So now you can see the rubber dam barrier isolate the saliva, isolate the spread of virus. The saliva ejector is there. If there's any fluid, any saliva there, it sucks up right away. And if there is anything coming out of the tooth, then we have high-speed suction. Now you tell me where the spread is coming from now, because you are really taking care of the contagion, the microbe, the viruses before they even hit your clinic. Okay? So to me, this is an innovation. Next thing is working length determination. In endodontics, the use of apex locator is an efficient and very reliable. Every clinician must learn to use this gadget if you want to do the root canal. There are different kinds of apex locator available in the market now. What you see on the left is commonly used, the Root CX. The picture you see in the middle, you can see the picture of the tooth. The apical foramen is on the side. The apex of the tooth is right at the tip. If you have to treat this tooth by using radiograph, you will be 3-4 millimeter outside the apical foramen because the foramen is on the side. There is no way you can see that on the radiograph. Okay, maybe you can see it after you obturate, then the sealer comes out. But before that, all the instrumentation you will be doing will be based on X-ray. Okay, so you can see the tip of the tooth is somewhere else, and the apical foramen is somewhere else. And the only way you can find out is by the use of apex locator. The current generation of apex locator we have right now is very reliable, more reliable than even a clinician, because when you read these X-rays, everybody reads the X-ray differently. The picture you see on the right is we have state-of-the-art technology now. We have rotary handpieces with built-in apex locator. So we have a simple electronic apex locator technology, and we have state-of-the-art, very expensive. I would say all those people start from the basic. You can always upgrade, but without this technology, I cannot even imagine people doing root canal using these. So next innovation in endodontics, I think in this time, is electronic apex locator, and we must be using it. As far as the instrumentation is concerned in endodontics, at this time, rotary endodontic files made of nickel titanium are tremendous. People ask me all the time. I have taught different techniques, different type of files, different part of the world. I think regardless of the rotary file system you use, rotary files have made endodontics very efficient, very effective, very predictable, with less post-operative pain. It's a real valuable contribution to the health of mankind. We have really reduced the time we spend on patient. Again, if you take my rotary nickel titanium files away from me, I don't think I can do endodontics with hand anymore. So rotary nickel titanium files are safe, they're efficient, they're effective, and we must be using that to get the best result in our practice. Next is irrigation. We are still using the same irrigation material, which is sodium hypochlorite, from 3% to 6%. We have seen a lot of modern devices available in the market. They range from ultrasonic to sonic. We have seen negative pressure apparatus. We have seen innovative irrigation needle. All these things, what they do is they give you better penetration and evacuation. Okay, I would say you can use sonic. What you see is the picture on the left is a sonic device. You put the sodium hypochlorite in the canal, and you just vibrate this, and you just spread the solution, let it go in the crevices and the canal to clean. What you see on the right is the ultrasonic. Again, they are both very valuable tool to get better cleaning and shaping of the root canal system. Okay, so effective and reliable method of canal irrigation and tissue removal using sonic and ultrasonic is a great innovation, and I think we must be incorporating that in our practice. As far as obturation is concerned, we are still using the same material we were using almost 100 years ago. Gutta percha is still the filling material. There are various obturation devices and techniques which are available, but the material is still gutta percha. We can use lateral condensation, we can use vertical condensation, you can use warm lateral condensation, you can use injectable with the down pack technique. I think, in my opinion, if you look at all the experts, the hundreds and thousands of articles which are available now, almost all system works. You can even use single technique. Okay? So there are, I think the best method of doing obturation is the method that works for you, that gives you the best result. Clinically, if you look at all the articles, hundreds and thousands of articles, they tell us that the success rate is almost the same. Okay? We have seen some sealers in the market currently. The options of sealer we have are zinc oxide. We have resin-based, calcium hydroxide-based, and bioceramic sealer. The latest trend in innovation now is to reduce the time by using technique is a single cone technique using bioceramic sealer. With the O4 taper file, or O6 taper file, or O2 taper file, regardless of the taper of the file, regardless of the technique of canal preparation, more and more people are switching and using a single cone technique using a bioceramic sealer, because we have learned the seal you get, a better seal you get is from the type of the sealer, not the way you inject or place the gutta percha. Bioceramic sealer with gutta percha gives you what we call a monoblock picture. The binding of the material sealer gutta percha with the canal wall is better with this technology of single cone and bioceramic sealer than vertical condensation, lateral condensation, or injectable technique. Okay? We have innovations now that we can do regenerative endodontics. We can go beyond the apex and create hemorrhage inside the canal and regrow pulp. We are taking stem cells and putting it back in the canal. There's a lot of research going on that, and the results are very promising. We are taking cells from the periodontal ligament, we're putting in the canal and trying to regenerate the pulp cells, pulp tissue. So there's a lot of work done on regenerative endodontic, and use are very promising. We are also doing more use of MTA for pulpal exposure, whether it is pulpotomy or partial pulpotomy, even those cases where we have adult tooth, which are closed apex, a symptomatic tooth, we are doing, we are putting the MTA on that and let it close and putting the restoration, and we have seen very good results on that. So I think regenerative endodontics is very promising, and we must use that, at least the use of MTA for pulpotomies and partial pulpectomy, most often in cases with immature apex. Even with mature apex, it has seemed it works very well. Okay. The other thing we have to learn to provide innovations in endodontics is how we can provide the emergency endodontics, especially in this condition. We sometimes don't have enough time to perform the procedure. What is the minimal we can do to get patient out of pain so we can bring it back? Or what is the maximum we can do to get the best efficiency and effectivity of our time and the procedure? So as far as the emergency endodontics is concerned, if you have an anterior tooth and it's non-vital, all you can do is open and drain. If you open and drain, that should give enough comfort to the patient. You don't have to do much. So in this novel situation, I was performing emergency endodontics even 2 months ago when we were in lockdown. I was seeing emergency patient, but we were doing the minimal we can to get people out of pain, and it worked very well. But you have to know this technique. You have to know the procedure. You have to know what you can do. You have to know what is the little you have to do to get the result. You have to know what the maximum you have to do to get the best result and the best achievement of your time and the money. Because right now, economy is a big factor. Okay, with the PPE you're using, the mask and the cover and the headgear and the staff time and the downtime, if we can achieve the maximum. So if you have a non-vital tooth, you don't have time, you just open and drain and close and you're done. If you have enough time, you can complete the instrumentation on a non-vital tooth, close the tooth, bring the patient back. We try not to finish one with a root canal on non-vital teeth. If it's an anterior tooth and the vital tooth, you can do the pulpectomy. What pulpectomy means is you can open the tooth, you can take the pulp out. You don't have to finish the instrumentation. You just take the pulp out. Let's say if it's an anterior front tooth incisor, you can go with number 10, 15, 20, 25, get a quick working length. With the digital radiography, with the rubber dam, it doesn't take that long. So you get the working length, you take the pulp out, you don't have to finish instrumentation, close the tooth, bring the patient back. If you have enough time, if the patient have time, if everything is working out well, you are on schedule, patient has the ability to pay, you can go ahead and complete a root canal on a vital tooth. Remember, every time you bring the patient back, it costs money. it caused contamination, it caused resources. So whatever we can do, and the only way we can learn to do this is if we know scientifically what can we do, what's the little we can do to achieve the result, and what is the maximum we can do to achieve the result. Now, the last thing you can do, and this is what we are doing now, we are doing more and more now under COVID-19, is if we can complete the instrumentation, we can complete the obturation, we can complete the root canal treatment, we even complete the restoration, we even prep the crown. Okay? We put the temporary crown. Next visit is going to be only a few minutes just to cement the crown, especially those patients who have aesthetic concern. It's a front tooth. It works very well for them. And the only way we can do this is if we know what we are doing and what can be done. As far as the emergency condition is concerned, in posterior teeth, if it's a non-vital tooth, you can open, drain, and close. That's all you can do. Just open the tooth. If there is discharge, you don't have to even put a file inside the tooth if you don't have time. Because once you open a tooth, you relieve that pressure, you let the oxygen go in. Most of the bacteria in non-vital infected teeth is gram-negative bacteria. They are anaerobes. As soon as you open the tooth, oxygen go in, air goes in, it destroys a lot of those bacteria, it relieves the pressure, patient feels fine. You can open, drain, close the tooth. You don't have to do much. You can do pulpectomy. You can go in there, go with number 10 file, 15 file in the mesial canal of the lower molar, maybe number 20 file in the distal canal. Don't just go in there, do a little bit and come out. If you do little bit, it will cause more pain to the patient than they came up with. Okay, so just do enough pulpectomy. Go with number 10, 15, maybe 25. Do enough instrumentation that even if you have to put medication in there, which is mostly calcium hydroxide, you have enough space created, you can do that. In emergency condition, we don't even put any medication if there's no need to. Or you could, the last thing is you could finish instrumentation. You can go ahead and complete instrumentation and on a non-vital tooth. If it's a vital tooth, you have many choices. You open the tooth, you can do pulpotomy. You don't have to pick a file. You open the pulp chamber, go with your spoon excavator, go with the bar. Bar is a little more dangerous when you are in the chamber. You open the tooth, you say on a vital tooth, in a multi-rooted tooth, which is a molar or a bicuspid, and you take your spoon excavator, scoop the tissue out. Again, you're relieving that pressure symptom. Close the tooth. If you want to put a medication on the top, fine. The current concept right now is we are using as little medication as possible. So you do the pulpotomy, you close the tooth, bring the patient back to finish. You can even go ahead and finish pulpectomy. You can even go ahead and finish instrumentation on a vital molar tooth, but you have to be very efficient. Okay? That's why if you're not efficient, the way the things are right now, send it to an endodontist. Send it to somebody who is more efficient. Okay? You can finish instrumentation. You can even finish the root canal, and you can even finish the restoration. So these are the things we have to learn for practice management, to manage time and manage things. Many people now, they are getting together, 3, 4 dentists together. One is getting more efficient to do one procedure, and the other is in different procedure, and patient is in their office. One dentist come in, does the endo, the other dentist comes in and does the restoration. So there are 2, 3 dentists in the same building, in the same office. They're more efficient doing those procedures. I think with the innovation amid COVID-19 pandemic, we have to be very dynamic. We have to change. We have to be very current, listening to CDC guidelines, World Health Organization, local organization. We have to be very dramatic. Okay? We have to adapt. We have to adapt on a daily basis. I am changing things on a daily basis. There are updates coming on a daily basis from all over the world. And I think the last thing is we have to be a strategist. We have to plan. We have to plan. Even now, we have to plan when we build our office. what kind of office we're going to build, what is going to be the best way for airflow, for air filtration. Patient come in, how little do we are reducing the size of the waiting room. Or some people are expanding the size of the waiting room so we can accommodate these patients with social distancing. More technology we have, more knowledge we have to have. When you have 787, it doesn't mean that you have less knowledge to fly big planes. Actually, bigger the plane, bigger the technology, more the knowledge. Same thing with endodontics. You know, to get the efficiency, to be innovative, we have to learn more things. We have to learn the use of technology, and we have to learn the latest technique we have. We cannot be like a butterfly. We cannot spend a lot of time going from room to room, patient to patient, and spend a lot of time to achieve what we want to achieve. We have to transfer. We have to adapt. Like you see here, we have a lot to learn from the animals. Okay? They adapt according to the circumstances. If we want to survive, this is what we have to do. Just like how the hummingbird survived over 40, the dinosaur, the big animals are gone, but this little 2 to 3 inch bird is still there. And the secret they're still there is because they knew how to adapt. Okay? So I again, in my opinion, uh, we have to be more dynamic. What we call DDS. We have to be dynamic. We have to be dramatic, and we have to be strategist. And I think the future of dentistry is very good if we prepare ourselves. I know we are getting back into our practice. We're getting busy again. Patients are coming in, and I see future is good if you're ready for the future of dentistry, following the guidelines and preparing to use the technology and the technique. And I thank you very much.